Thank you so much for joining us for our lower extremity arterial duplex lecture. Today we are going to look at how we want to be scanning our arterial duplex exams to prepare you for doing that in the field if you're not already doing it. So first of all, our objectives, you're going to describe the ultrasound techniques used to image the lower extremity arteries, define normal image and Doppler characteristics of peripheral arteries, identify peripheral artery abnormal waveforms, and describe the use of ultrasound with arterial revascularization procedures. One other thing to keep in mind with our arterial scans, sometimes they will be preceded by ankle brachial indices waveforms or ABIs. So in certain circumstances, it may be that an ABI is performed initially. If the patient does not have a normal outcome of that study, then you would move to the arterial study of that limb. So just be aware, sometimes other sites may request that you go right to the full arterial study. Indications for our lower extremity arteries are going to be intermittent claudication. And if you're not familiar with what claudication is, it is when a patient will experience the same sort of pain after exactly a particular amount of exercise. So say for instance, a patient has some arterial disease and they usually have no pain in their legs, but every time they walk down to their mailbox, they get pain at exactly the same location on their walk every single time. The reasoning for this is that because when their muscles have low metabolic needs during rest, their body is able to meet those needs. However, when they start increasing activity, the muscular needs get higher, and because of arterial disease, they wouldn't be able to meet that need. And so at that same point in activity, they'll get this pain, which will resolve after rest. So you'll want to question your patient about intermittent claudication, exactly how far in a walk or upstairs or when it is that it hits them, how long that's been occurring for, and if it improves upon rest. The other indication would be just simply rest pain in the lower extremity. This could be more, indicate more significant disease than just the claudication. Other indicators might be non-healing ulcers or gangrene. That would mean that the blood supply is not adequate enough to get that immune reaction to areas of insult, and that can result in ulcers or gangrene. And then trophic changes, a loss of hair, nail thickening, skin thinning, excuse me, all of those would be additional indications. So make sure when you're working with your patients, you're getting a really good indication and history from them. And then you're going to begin a physical exam. So some other signs that we see of arterial insufficiency is pallor or paleness of the skin, pulselessness, paralysis, paresthesia, intense pain, or coolness. And when you're doing a lower extremity arterial, especially if you're doing it bilaterally, or maybe if you just have a patient with pain in one particular side, you're going to want to make sure and evaluate and compare the color on both of the legs, looking for pallor. You're going to want to evaluate the pulses in each leg at the femoral artery, popliteal artery, and posterior tibial artery. And you're going to want to classify the pulses at each of those levels and compare their right to left. A decrease in pulse strength in one leg or the other would indicate that there may be some restriction or stenosis that could be reducing the amount of blood flow to that area. Paralysis, this can occur again if you're not getting enough blood flow, so that would be watching the patient's gait and things like that. Intense pain could be because of a lack of perfusion to the leg and would be indicated in their movements and their ability to tolerate the exam. And then finally, coolness. We know that if arterial constriction occurs at the skin level, it's that blood that brings warmth to the skin. So a coolness could indicate that there's some obstruction or limitations to the blood perfusion in that area. Another sign you could see is a palpable mass, which would indicate an aneurysm. And so this could be, sometimes the masses might be really difficult to identify in the deeper arteries, but what you'll find is you might be able to find these at the common femoral artery, superficial femoral, and popliteal area. Examination for aneurysmal diseases with a known abdominal aortic aneurysm is going to be important, because if the patient is creating or having that weakening of the vascular wall in one area of the body, that could indicate that they have some sort of connective tissue issue that would allow them to create or have aneurysms in other areas of the body. So that's definitely going to set your radar up if you know they have a known aortic aneurysm. Okay, and other less frequently encountered arterial diseases that you may find in a patient are really due to traumatic injuries or iatrogenic injuries and things of that nature. So some of the things that put us at higher risk for arterial disease would be diabetes, hyperlipidemia, hypertension, smoking, coronary artery disease, and end-stage renal disease. Also obesity, sedentary lifestyle, heredity, age, and gender. And if you ever are trying to memorize all these and find that that's really hard to do because there's so many, really put this in context. We know when somebody has diabetes, they have a lot higher levels of sugar typically in their vascular system. And over time, as that sugar runs through their vascular system, it can be basically roughing up the vascular walls, because we think of sugar crystals as kind of sharp little shards running through the vascular system. So when those sharp little shards run into a vessel wall, they can cause a small injury. Now, that can be corrected with a fibrotic change, and that fibrosis can narrow that vessel. In addition, it can make it rougher in that area. And so if a patient also has hyperlipidemia, excess lipids in their blood, then those lipids are more likely to get caught up on that rough area and again develop stenosis. Hypertension is pushing a lot more blood through that system, or and so it can insult or injure the wall, which would lead to the building up of plaque or fibrous changes that would stenose the vessel. So smoking is similar to diabetes in that it puts a lot of nicotine into the system. That nicotine can affect the health of the vessel wall and really initiate that beginning trauma that will then build up to be a stenosis. Now, if somebody has coronary artery disease, that means that they probably they have vascular disease in their heart, and the vessels in the heart are also going to be very similar to other vessels throughout the body. So if damage has been done in the heart, it's likely to consider that maybe they could have had damage in other vessels as well. And then a lot of these things really go with obesity, sedentary lifestyle, but things like heredity, gender, and age, those are really out of our control. So they're not so much lifestyle factors. They're more just the normal biologic aging process, and you know, those gifts we either receive or don't receive through our genes. Okay, patient preparation for these is going to be very similar to your lower extremity vascular. A lot of the exam is completed with the patient supine. Again, their leg would be flexed slightly at the knee, as you see here, and abducted with access to the groin area, because we're going to start this either from the iliacs or from the common femoral artery, depending on your site's protocol. Now, once you get down towards the adductor canal, right about here, sometimes it can get difficult to access the popliteal from behind the knee in this position. If that's the case, it never hurts to have your patient roll over and provide you access to the popliteal arteries right here, and then you can bring them back to this position when you're ready to go to the posterior tibials. Make sure that they're removing all the clothes from the waist down. If they can, if they have underwear or shorts on like this, and they can be pulled up above that, the crease in their groin, then those would probably be acceptable. So you wouldn't have to have them change all the way. Okay. It is important to try and keep the leg you're not scanning covered as to keep it warm and promote better flow if you are to move to that extremity next. So the technique with this, you're going to use the highest frequency linear transducer that you have available and that can get the penetration that you need. So lots of times this is going to be a linear 9 and up. Now that will work really well at the popliteal area, at the common femoral area, and in the distal posterior tibials. However, we know that as some of our veins go quite deep, such as the profunda or the perineals, things like that, we might have to change to a curvilinear to get that increased penetration to access those thicker vessels. When we begin this exam, we're going to really start out with our grayscale imaging our grayscale imaging. We're going to image in grayscale in long and transverse, looking for the patency or the opening of the vessel. Make sure that you're ready to adjust your dynamic range and your gain, your TGC, things like that to optimize your visualization of the vessel wall. Once you've done documentation and evaluation of the whole arterial system in long and transverse, you can do color and flow images as well. So you'll want to document the image in B mode, add color, add spectral, and that will give you a complete view of what's going on in the vessel. Now, when you're working your way down the leg through the vessels, we're going to start at the common femoral typically, although if there is concern, you can start at the common iliac. So let's say you're starting at the common femoral right there at the groin, and you're going to evaluate the common femoral and its bifurcation into the profunda and the superficial femoral. You would evaluate that at the bifurcation level in long and in transverse, and you would document it in B mode in long and in transverse. And then at the same level, you'd add color, and then you would take your spectral waveforms of the common femoral artery, the superficial femoral artery, and the profunda as you see them bifurcate. So you would take 3 different spectral samples here in the common femoral, superficial femoral, and profunda. Okay? Now, as you work your way down, we don't really watch the profunda because it drives so deep into the body. But as you work your way down the superficial femoral, you're going to image that superficial femoral all the way down the vessel. So you can go back to transverse so you don't slide off of it, and you're going to evaluate one section at a time. However, you don't need to take an image constantly as you go down the vessel. What you want to do is do a proximal, a mid, and a distal. And then when you get to the popliteal, you're going to want to do just a popliteal. So you're recording every major arterial segment, but you're not recording every image that you look at. Okay. Okay, moving forward. So we know that our grayscale, it really is going to allow us to assess the lumen of the vessel, look for any plaque or disruption on the vascular intima, and evaluate the patency of the lumen that way. When we turn on the color and or power Doppler, we know sometimes if we're having difficulty picking up color flow on a particular artery by accessing power Doppler, it's a little bit more sensitive, but it doesn't usually give us any directional information. So in cases where you're really struggling, you can utilize power Doppler. However, you don't have to use color and power. It's one or the other will do the trick. Now, the purpose of the color is to assist with localization and tracking of the vessels. So if you've lost a vessel in B mode and you can't identify where that vessel is, sometimes by turning up high sensitivity color, it'll allow you to re-find that vessel and get back on track. It also allows us for a really brief or rapid assessment of flow dynamics. So we know that if I'm looking at a vessel, I have a scale set here with my color flow. And that scale, depending on the hue of either red or blue in my scale, is going to give me a general idea of the velocity of that flow. So it can tell us, if I'm coming into a stenosis here and I am seeing the highest level of my flow in the center of that stenosis, I know that that is where my highest velocity is. So it can give me that rapid assessment of flow dynamics. That will help me place my spectral Doppler. Now, just distal to that stenosis, I might start to see some mixing of the reds and blues. That would indicate that that's a turbulent area, and I would need to utilize my spectral to support that. So really, it allows us to see, you know, the fill of the lumen. It allows us to make general assessment of velocities, and it really can help us place our spectral Doppler, which is what we're going to talk about next. The lack of color, however, can indicate that there is full occlusion, although you want to be very careful in making that determination, because even if a vessel is fully occluded, there's 0% of blood getting through that stenosis, that's typically considered inoperable. If there's any sort of string of blood flow at all moving through here, they can often still operate. So it's very essential in patient care to ensure your patient's getting the best care they can, that even if the tiniest amount of flow is getting through a stenosis, you've got to find a way to demonstrate that, and sometimes you'll have to go down to that power Doppler to get that done. Now, spectral Doppler is our third stage. So when we're adding our spectral Doppler, we're going to be assessing in every instance that we're taking a color image, and I mean saving the color images at those prominent vascular anatomical points. Every time we're doing that, we're going to want to add spectral to it as well. The peak systolic velocity, as well as any end diastolic velocity, should be recorded at each of the major vessel segments. Now, what we see in our waveform changes is that if you know that the lower extremity is a primarily muscular area, muscles don't have a lot of metabolic needs when we're at rest. So if you're on the couch, your feet are up, your muscles don't have a lot of need. Therefore, they're going to have a pretty high resistance waveform. So what we'll see is a good systolic upstroke. It'll rapidly fall off during early diastole. If there's lots of resistance ahead because the muscles don't need a lot of blood flow, you're going to see it fall below the line in early diastole. And then when that hemodynamic pump or Windkessel effect kicks in, you're going to get this slight little brief bump of forward flow again through end diastole. Okay. So this is a pretty high resistance but very normal waveform if you have a patient that is at rest. Now, let's say my patient got on the treadmill and ran for 2 hours. Now, those muscles are pumping, their metabolic needs have increased significantly, and you're going to see a lot lower resistance waveform where those muscles are saying, give me blood at all times. I'm not going to push back on you at all. So you'll see forward motion in systole, and then in diastole throughout the whole diastolic time here, you're going to see forward motions because those arterioles that are feeding the muscle cells are going to be dilated and allowing that blood flow to easily flow through, not providing any resistance, which would reverse the flow. So this is what I would expect to see from somebody that has a very normal flow after exercise. Now, if we see somebody that has a stenosis up ahead, and we know that that stenosis is probably going to cause increased resistance beyond what the arterioles are already providing. So if my blood flow is coming in here, it's already got high resistance because my patient's at rest, their arterioles are constricted, and my muscles don't need a lot of flow or perfusion. So it's already going to be something like this in the normal state. Now, if my patient then has a stenosis, that's going to increase the resistance even more. So you can see things which will occur where you're seeing an even farther drop below baseline, and oops, I don't know what's going on here, farther drop below baseline, and once the Windkessel effect kicks in, that's not enough pressure, it's not strong enough to get it above the baseline like we see here. And so you would just have what we call a biphasic flow, and systolic upstroke, but diastolic, early diastolic that stays below the line until the whole next systole. Okay, so that could be increased in our stenosis. Now, once I get into my stenosis, the pressure is going to drop because of what Bernoulli's principle. The pressure drops here, but the velocity increases. And so at this point, you might see a lower resistance waveform, kind of like a more normal waveform here, but you're going to see the velocities in this area increase significantly. So making sure that you take that peak systolic velocity is going to be essential. It's those numbers that help us classify the severity of the stenosis. So it's going to be really important that you get those accurately. Now, once you get to posterior or beyond the stenosis, what we'll often see is some turbulence. So here you kind of lose all of this normal form that we're looking for. And you can see some forward motion, you can see some backward motion, you can see low velocities because it's like a little bit of water washing around in a large tub. Okay, so you can see things all over the place indicating turbulence. Okay. Now, once that blood gets out of turbulence and gets going forward motion again, what you'll often see is that a lot of the velocity that our blood coming into that stenosis has is lost. And so what you'll end up seeing is there's not as much blood distal to the stenosis as required by the tissue bed it's feeding, and so you can see it become much lower velocity, something like that. Okay, all right. So more about the technique of how we're going to do this. So we talked about starting out in B mode. We're going to do transverse, we're going to do long, assess the vessel walls, and then we're going to put color on it, and we're going to look for lumen fill. We're going to assess where the highest velocities are, and then we're going to add our spectral. So where are we going to do all this at? So we're going to start right up at the groin, like I said. However, if you felt like the groin waveforms looked abnormal, we know that we can get stenosis in the iliac artery. So it would be reasonable to go check out an iliac artery and make sure that it's patent. All right, but on our most common or our most basic exams, we're really going to start at that common femoral artery right at the groin. We're going to see a very short bit of the common femoral before it bifurcates into the superficial femoral and the profunda. The profunda is going to dive deep, so again makes it very difficult to be able to evaluate. So then we're going to evaluate our superficial and our profunda and our common femoral all in this area. B mode, transverse, long, color Doppler in all three, and then spectral Doppler in all three. Once we've done this, we want to follow our superficial femoral, and we're going to do the transverse, long in B mode, and then we're going to do color, and then we're going to do spectral. We'll follow it in B mode and color all the way down the vessel. We'll image it in B mode, color, and spectral at the proximal, mid, and distal regions. Then we're going to go behind our patient's knee, and we're going to make sure that we overlap and that we're following that popliteal throughout the whole popliteal. Now our popliteal, because it's a short artery, we really only need to get one representative set of evaluation images here at the popliteal, right at the mid. So you'll get your B mode 2D, or excuse me, B mode transverse, B mode long, color, and Doppler just once in your popliteal. Then you're going to continue down the popliteal, scanning in B mode and transverse, looking at all of the vessel, and that will take you to the tibioperoneal trunk. So your posterior tibial artery is going to pop off of that popliteal artery, and what you're left with here is this tibial peroneal trunk. And that tibial peroneal trunk is then going to divide into your posterior tibs and your peroneal. Now, this is where you're going to have to split up a little bit, because you need to follow that anterior tibial, and you're going to image it proximal, mid, and distal. And then you need to follow the peroneal and the posterior tibs and follow it, evaluate it, image it proximal, mid, and distal. Now, sometimes you can look at your, sometimes you'll get lucky enough that you can see your posterior tibs and your peroneal all in the same image. Other times you may have to image, you might get the posterior tibs with a linear and then have to image the peroneals with a curvilinear. So sometimes you'll get them together, sometimes not, depending on this patient's calf and how easy of a scan they are. Okay. I talked about most of this already, but like I said, the popliteal artery is examined through the popliteal fossa. This is one that it can be helpful to have that patient roll away from you. If you are seeing branches off of that popliteal artery, be aware that multiple gastrocnemius branches that feed that gastrocnemius muscle come off in that area. So that's probably what you're seeing. All tibial arteries should be examined. So that includes your anterior tibial and your posterior tibial. We can see that anterior tibial is going to be the first bifurcation off the perineal once it gets through the knee. And then once it leaves that, we can follow it with the anterolateral approach, coming out that lateral aspect of the anterior calf. Then we're going to look at our posterior tibials. Those are going to follow our medial calf. So it would be from that medial malleolus deep into the calf, deep into the posterior calf. And then our perineals are going to be deep in the calf, posterior to our posterior tibs. Now, these vessels are pretty small, and so these might be ones that you're not getting really great blood flow through. So make sure that you're providing just light pressure so that you're not compressing the vessel, and make sure that you have adequate color gain settings, or go to color power Doppler if necessary. So here's a great example. So here we're going to start out. Here's our common femoral artery, splits into our superficial femoral and our profunda. So I would have already imaged this in B mode, transverse at all three levels of all three vessels, and then in long in B mode, and then I'd add my color like here. And then the next step I would do would be to go ahead and take a spectral here, here, and here. And because we are assessing for velocities, we need to be very, very careful that we're maintaining good Doppler technique, meaning that we have the angle at 0 to 60 degrees, ideally 30 to 60 degrees, and that the angle of our gate is parallel to the angle of the wall. So you'll have to be doing those adjustments to ensure that you're getting good, accurate Dopplers at each of those sites. Now here's if we were to follow the superficial femoral artery all the way down, we assessed it in proximal, mid, and distal, then we pop behind the knee and we're looking at the popliteal, and I see this artery coming off the popliteal. That would be our gastrocnemius, a gastrocnemius artery coming off of there. Now if I'm distal to the knee and I see this coming off, there's a possibility that that could be the anterior tibial. Okay, so here we see, here's the popliteal, here's the anterior tibial and the tibio-perineal trunk. So anterior tibial comes off, it's going to go down the lateral anterior aspect of the calf. If I continue to follow this here, this tibio-perineal trunk distally, you'll see then it's going to bifurcate into the posterior tibial artery and the perineal artery. And these are both, you're going to have to follow both of these down the calf. Throughout the evaluation, we talked about all the different approaches you're going to be taking in your scan. You want to make sure that you're evaluating arterial size, length, any degree of narrowing, evaluate the plaque, and provide assessment of the characteristics. We can say it's either heterogeneous, homogeneous, and identify whether it's shadowing or not. The terminology used of ulcerated plaques, things like that, are really more frowned upon now. So you want to be very distinct in just, it's heterogeneous, it's homogeneous, it's this large, and it's shadowing, yes or no. If you find an aneurysm, make sure that you are evaluating it thoroughly. So just like we would do an abdominal aneurysm in somebody's abdomen, that's very common, we're going to want to make sure that we're evaluating it in long B mode, transverse B mode, and then we're going to have to evaluate it in transverse proximal to, at, and distal to. And we're going to take measurements of the width of it in each of those three locations. So you do transverse proximal with and without measurements, transverse mid with and without measurements, transverse distal with and without measurements. You also want to, in long, in this image here, measure the length of it. Okay, then you'd go in and you'd add color. So when you add color, you want to make sure that your settings are appropriate, because we want to see that that aneurysm should be demonstrating turbulence throughout the whole vessel. Sometimes an aneurysm can develop a thrombus in one area of the vessel, and stop blood flow from entering that area. So utilizing color flow in this image is going to be essential to determine if the lumen has thrombus in it or if it is free of thrombus. Okay, so what do we want to see in our B-mode imaging? We are looking for normal arterial walls. Those should be smooth and uniform. If we can see well enough, which can be very challenging because of the depth of these vessels, you can see the tunica adventitia, the thicker muscle tunica media, and then the echogenic tunica intima. Now, again, a lot of these vessels are so deep, you're not going to be able to appreciate those, but just know they should be there, and if you can see them, assess those. We're going to be looking for atherosclerotic plaquing. This could be, like I said, identified as homogeneous or heterogeneous, smooth or irregular. We can assess it by how calcifications and shadowing and that those type of terms, but we want to avoid, again, fatty, ulcerated, things like that. Okay, the strengths and pitfalls of these exams. One of the strengths is that it's portable. We can take it to, even if a patient's in bad shape, we can take it to their ICU or wherever they need the exam done. Usually by the time the technologist has completed the exam, they have almost immediate exam, almost immediate assessment of that exam. And so the physician should be able to report on it almost immediately. Well, one of the standouts in our ultrasound evaluation is that we can actually see the arterial walls. Whereas if you have a history in, if you have a history personally in radiology, you'll know that sometimes, say, the coronary arteries, they can inject contrast in there, and we see where that coronary artery is by its fill. Well, if there's a plaque in there, we don't really see any information about the plaque. We just see that it's an area that's not filling with contrast. So that is one of the positive benefits of ultrasound versus, contrast angiography. Okay. It also allows us to visualize acute and chronic changes. So over time, plaques can change, so we can look for some of those changes, and we can see things real time. We also have the ability to evaluate vascular segments as needed for intervention. So you don't have to inject contrast that'll affect the whole body if you're doing an ultrasound exam like you would with an arteriogram. You can just assess the area of interest. Pitfalls. If you've done these exams, you know they can be challenging. So we can have calcified vessels, which can cause a lot of shadowing through the vessel and make it very difficult to assess the vessel either in B mode with color and even in spectral. Other pitfalls are that some of the smaller arteries, towards the distal leg, are going to have extremely low flow. So it can be challenging to pick up flow patterns, get good color on these really low flow areas. And some patients have thicker legs than others, whether it be muscular or soft tissue. And so some of that depth can really affect our ability to pick up flow. Sometimes these patients can be uncooperative, which always makes things more challenging. And other times they may have a significant, other health issues, significant swelling, maybe cellulitis, things like that can cause a lot of pain and make them very difficult to visualize on. Finally, the exam length can be really long and uncomfortable for the patient and a lot of work and challenging for the technologist. So that's something certainly to keep into consideration, especially if you're doing these bilaterally. Okay, so abnormals, if we talked a lot about what we should be seeing, here's just some examples of some of those abnormal things that we talked about that we may find. So here you can see a vessel and you see that we got good color fill here. It looks like they had to use power Doppler, but we get good color fill with that power Doppler, and it shows this irregular border within the vessel. So that would indicate if this is the popliteal artery, that there's some plaque here affecting the flow through that popliteal artery. Here you see this is a posterior tibial artery. We should see nice smooth flow in here, and you're seeing what almost is reminiscent of the vertebral arteries, except this is in the leg. So vertebral bodies, arteries, it's normal to have shadowing because the vessel is running through the cervical foramen. But here, it's not normal to have this shadowing, and this would indicate that there's some sort of plaque we're not seeing, but we're recognizing the shadow from it. Here's a great example of an aneurysm with a thrombus, as I briefly mentioned. So somebody can have many, many different aneurysms. Some people will just have one. It can be present, it's considered present, or it's considered a true aneurysm when the vessel is 1.5 times greater than the proximal and distal vessel. Now, if the whole vessel is larger than expected, then that would be considered less of an aneurysm and more of an ectatic vessel. Now, whenever you see an aneurysm like you are here, like I said, we want to put color on it. We expect to see turbulence in an aneurysm, and so this lack of turbulence that we're seeing in this instant is really indicating that there's a thrombus blocking part of the vessel wall, which makes it almost look like it has a normal lumen. So those can be sometimes challenging to identify if you're not getting a really great exam, but it's going to be very important because these will serve as an embolytic risk. Okay, color and spectral flow findings. We talked a little bit about this. We know that normal color flow should completely fill the vessel lumen. We have to pay attention to things like setting the wall filter appropriately, using the appropriate scale, using the appropriate gain. And when we have all those things set just right, we should see a nice full lumen. Color should be uniform and limited to the lumen only. If you have flashes outside the lumen, you either have your wall filter too low or you have your color Doppler gain too high. If I have turbulence, that would indicate an abnormality. If I'm seeing that mosaic or the mixing of the red and the blue, that would indicate a post-stenotic turbulent event, and that would indicate an abnormal finding. And other abnormal findings include aliasing, like I just mentioned. That would usually be from that post-turbulent event. Reduced flow channel. So it looks like I have a nice big vessel, and then when I put color flow on it, that color only fills part of it. That would indicate that there's a plaque there, maybe it's fibrous or something else that's displacing that flow, and that will give me another chance to identify a plaque that could be harmful to this patient. And then a color bruit, where you see if there's a significant stenosis, we know that the velocity at the narrowest area is going to be the highest velocity there is. So we call that a color bruit when we see this bright hued velocity going through a stenosis. Now, normal spectral findings, we know that the peak systolic velocity should not be increased. So it means if we have a normal range of peak systolic velocity, it might go down depending on the activity and the needs of the metabolic needs of the muscle, but it should not go up. So what we're expecting to see, like we talked about early in this lecture, is that you have a sharp systolic upstroke, rapid deceleration, reversal here if we have significant arterial resistance just because of limited blood flow need, and then we have brief antegrade or forward flow during Wind-Kessel effect. This is normal. Now again, we talked about if I increase my vascular need, I'm still going to see that systolic upstroke, but I'm going to lose that resistance that pushes the blood flow backwards. So we're going to see something more like this normally in a patient that has just recently exercised. So here we see it again. We would call this a triphasic waveform. I have one phase above the line, below the line, above the line. That equals 3. That means triphasic. So this would be a relatively normal, or a normal appearing spectral waveform. We also see that we have a nice open window under our waveform here, and that would indicate that we're getting a nice clean sample. Our gate is nice and narrow. We're in the center of the vessel, and we're not picking up abnormal velocity patterns. Now, there are some charts that help us in evaluating these. So if I were to look at the normals, and you can print this out or have this available, if I was to look at the normals of what I would expect to see in my external iliac, it should be slightly less than 1 centimeter. Okay. And its peak systolic velocity should be around 119. Now, as I get a little bit farther in my common femoral, you're going to see that peak systolic velocity drop to 114, and then superficial femoral would be 91. Distal superficial femoral is 94, and popliteal is 69. So any of these, we have our standard deviations, and if we go below, that might mean the patient maybe just exercised, or maybe I'm post-stenosis. If I go above, however, that would mean that I'm either within or approaching a narrower area caused by stenosis. So how do we classify these? Once you get all of your information, you've taken all the values, you need to go back and check those values against the standards. So if we have focal velocity increases where our peak systolic velocity ratio of greater than 2, that would equal about 50% stenosis. If we have a peak systolic velocity ratio of greater than 3, that would equal 70% stenosis. If we add to those hemodynamic information, such as turbulence and other things, that can help the physicians assess whether what to do going forward with the patient. Now, distal to a hemodynamically significant event or stenosis, the spectral waveform will first demonstrate turbulence, like we talked about, and then it's going to have a more low resistance, lower peak systole. And we can call that a tardus parvus, where rather than brisk systolic upstroke, we have something coming tardy, tardus parvus, a much slower systolic upstroke. And that's because it's post-stenosis. And so it's not getting that great pressure directly from the heart moving it. That pressure is being dampened by a stenosis, and so it makes it move much slower with lesser pressure. Here's an example of distal to that stenosis. So because that stenosis is blocking a lot of the blood flow that was trying to come to this area, the metabolic need is not being met. And because that metabolic need is not being met, the arterioles are going to dilate and they're going to ask for more blood. And because of that stenosis, it can't provide that much blood. And so you see this very low resistance waveform. Here you see decreased arterial resistance. This could be for a number of reasons. Possibly the patient is just post-exercise and they have a really high metabolic need. But other issues may actually be causing this. Things like an AV fistula, where we're going right from our arterial system, skipping arterioles, and dumping right into a venous system. We have no resistance because there's no arterioles there. And so because of this, this would be a very low resistance waveform like you're seeing here. You might even see some, if you're very close to the AV malformation, you might even see some reversal here. If you have if you have trauma, that could indicate that the patient may be bleeding out. So if there's trauma to the vessel, they're bleeding out, it's ruptured before the arterial, obviously that is going to decrease the resistance to the incoming blood flow and give you a pattern such as this. Cellulitis and is our other culprit, where because of the inflammation in the surrounding tissue, it's going to basically dilate all those arterioles to provide perfusion to that tissue to address the inflammatory process. And then we already talked about how the only one of these that would be normal would be if it was a post-exercise evaluation. Now, proximal to an occlusion. So kind of think about this. If this is the vessel, here's the occlusion, or near occlusion, I should say. And I have this pressure from the heart pushing blood flow forward. And usually there's some need over here distal to the stenosis. There's some metabolic need. And that metabolic need is reflected in that normal waveform pattern. Now, if the stenosis really has it pretty much completely occluded, we're not going to see what's happening in our distal arterial area down here. What we're going to see is that my heart is pumping out blood. That blood is pumping down the vessel. It's ramming into this stenosis, and it can't go anywhere. And so you see that in systole, you get a brisk systolic upstroke here. Diastole takes it back to nothing. and then you have nothing until systole again. So this is like butting your head up against a wall. That blood just has nowhere to go, so it gets pushed forward and stops, forward and stops. Okay, other imaging studies to evaluate the arterial system would be your contrast studies, which are done under arteriography or under radiology. So usually this is a fluoro or a CT exam where the patient has contrast injected, and then they are imaged with radiation to look for the fill of the vessel and evaluate the continuity of that vessel. So the contrast arteriography, either under X-ray, fluoro, or under CT, is still considered the gold standard for diagnosis of arterial stenosis. It can be used when duplex imaging is limited, such as if a patient has severe arterial calcifications that are shadowing out the vessels, if they have a lot of edema or they're obese and they're difficult to scan, if they have extremely limited runoff, meaning that they don't have a lot of blood flow in the vessels, so it's hard to detect and evaluate the vessels themselves. If the patient has extensive skin wounds and you don't want to introduce the transducer in any sort of pathogens it may contain, then that would be another reason a patient might undergo arteriography as well. So arteriography, is used in the heart. It's used really throughout the body.